everybody. Welcome to episode 199 of the Core Consults RX podcast. Cole, we're almost there, man.
Are we?
200, and then we just shut it down.
So is now when we make a plan for 200?
Oh, dude, I'm way ahead of you. I've already got our guest ready to go.
We're going to keep it a secret?
Sure.
Okay.
I think you know who it is, but...
I have a feeling.
Yeah. We talked, and he's like, yeah, I'll be there. Perfect. That was easier than I thought. So
Turns out we didn't need to make a plan.
We didn't need a plan because it all works out. And then, until eventually it doesn't. So
someday it
200.
Won't. Maybe 300.
Maybe 300.
Yeah.
So it's been crazy. But 200 episodes, man, that's crazy.
I know. It's wild. Well, I'm sure we'll reminisce. Well, actually, we might not have time to reminisce on that one.
Yeah.
So maybe we'll reminisce now. 200 episodes. That's crazy.
Let's just talk about it for 30 minutes.
Though, how about this hurricane thing? I bet you're not worried at all.
So I admittedly have not been following it.
I had it until this morning when I got a notification that it got up, or yesterday when it was upgraded to a hurricane.
Is it on the way towards us? Because last time I heard it was like coming through Florida and potentially going like towards the Gulf.
Well, if you look at the cone of uncertainty, right, cone of uncertainty,
right,
it could be anywhere between us and the Gulf. So we have no idea.
Oh,
but
perfect.
My kid's daycare is already closed. They're making all these preparations at work and. I don't know what we're going to do. So it's those sorts of things that are annoying, even though it could just totally bypass us. It sounds like we will for sure get heavy rain, but...
Is it a 1?
I don't remember.
Okay.
It was like ebbing and flowing. It's called Ian. For anybody listening later and you're wondering which hurricane we're talking about.
Yeah, no, I did hear people at work talking about it today, but I got to admit I've not been following it.
In Charleston, we have to worry about them a little more than maybe other people across the country. But we haven't had anything significant in years.
We're overdue for one, I think.
That's what they say.
Unfortunately.
That's what they say. So there's one on its way.
We'll see.
Yeah. So if we're not back next week.
We'll be here.
It's because the studio flooded.
Sure. Yeah. Well, hopefully we're on the top floor. I feel like we'll be good.
Yeah. We can at least
record.
Wade through and record. Yeah.
Priorities.
Forget about the rest.
Priorities. So today we are going to be doing another accredited episode thanks to our friends at freece.com. So after this episode, you will go to the link in the show notes. If you are an unlimited member of freece.com, click that link. It'll take you to the learning modules for all the podcast episodes that are accredited, and you can do the post-activity test. When you first pull up the post-activity test, it'll ask you for a password, and you will use NEWHF, NEWHF, and that's all caps. That'll let you take the test, quiz, whatever you want to call it, and after you ace that, you'll get your 1 hour of continuing education credits for pharmacists and nurses. And if you are not a member of freece.com, you don't have an unlimited membership to have access to all of our accredited episodes, make sure you check out their library of learning opportunities. They have a bunch of different really good modules on there, live courses, all kinds of stuff. So make sure you check that out. There's a discount code to getting the annual membership as well in our show notes. So check all that out. Big thanks to freece.com, as always, for continuing to work with us. And the reason the password is NEWHF is because we have we'll call it new just because we already made the password that, but
we could have made it newish HF.
Newish, yeah. And the newish medication class that is now
or newest.
There you go. For class-wise, yeah.
Class-wise.
So, from a heart failure standpoint, we haven't had too many new medications that are, kind of moved up to first-line options for various types of heart failure. So not just REF, but also preserved ejection fraction, MREF, is also indicated in those patients as well. But our SGLT-2 inhibitors. So we wanted to kind of do things a little bit differently. Instead of going through a disease state, we're going to kind of basically just kind of discuss some of the trends of SGLT-2 inhibitors and how we got to the point now where we're using them in patients with heart failure, even if they don't have diabetes.
Right.
Because they started off as being a diabetes medication.
That's important, even patients without diabetes. But we've touched on them in the past. I think we did an episode highlighting their use in HFpEF. In the heart failure episodes, like the guideline episode, I'm sure we referenced it and kind of mentioned the trials and things like that. So today we're going to go a little more in depth so you can impress your colleagues with all your knowledge about the trials.
Oh, yeah.
And the names of the trials.
Right.
And why we use what we use and what might be preferred over other ones, right? So it's just like early in the what the cardiac benefit phase of the SGLT2s when, Farxiga was running around before they had a trial out saying that it was a class effect and all that kind of stuff. And they want to say those same things about the heart failure benefit now, but we don't really have data to support that. So we're going to talk about what is preferred.
Yeah. And I think, if we start kind of at the beginning, when, why we have some of these cardiovascular studies in the first place. When these new medications classes came out, the DPP-4 inhibitors, the GLP-1 receptor agonists, the SGLT-2 inhibitors, the FDA required them to do basically cardiovascular safety data and renal safety data because we knew that they would lower the blood sugar in patients' A1Cs, but we wanted to make sure they were also safe from a cardiovascular standpoint. And so if we're looking at some of our DPP-4 inhibitors, for example, we see like the Savior Timmy 53 study with saxagliptin, there was an increased risk potentially of heart failure with saxagliptin, whereas the sitagliptin, we didn't really see that same risk. There wasn't a benefit, but we didn't see the risk associated with it. So just because something's in the same class, we know that they're not created equal. And so these FDA was requiring these cardiovascular safety studies. And so it kind of all, it started off with, just basically patients who had type 2 diabetes and were taking one of these agents. And initially, the dapagliflozin, canagliflozin, and empagliflozin were the three only options available. And now we have ertugliflozin, or Steglatro is our newer option, and we'll kind of discuss that a little bit. But basically, these were being utilized in patients with type 2 diabetes. They were kind of a novel agent at the time, 2015, 16 timeframe.
Mm-hmm. Yeah.
And, so we knew they were lowering A1Cs, and so we included only patients with diabetes in these studies. So I have the Canvas trial pulled up. Just this happened to be the first one that I pulled from 2017, New England Journal of Medicine, and this was the canagliflozin study. And basically, what they ended up finding at the end of the study was that there was not just cardiovascular safety, but there actually was what seemed to be a cardiovascular protective aspect of these. When they look at the primary composite of cardiovascular mortality, non-fatal MI, non-fatal stroke, there was a significant difference between canagliflozin and placebo for non-inferiority and superiority. And then when you look at, for example, some of the secondary outcomes, one of them that sort of stands out is the hospitalization for heart failure, cardiovascular mortality, and hospitalization for heart failure composite, as well as some other options there. The renal effects also were impressive enough to all of these agents started looking at renal protective properties of these agents as well. But the heart failure ones, because we haven't had a new medication, especially when it comes to cardiovascular mortality in heart failure, in quite some time. Probably spironolactone and Entresto is probably the newest one.
Yep.
But that's still kind of in the same pathway. But we haven't had a new add-on class in quite some time, right?
Right. And so before that, so Canvas, and there was also went on to be with canagliflozin Credence, which was looking at renal outcomes, and we saw that with other ones as well. So I had EMPA-REG, and I was looking at EMPA-REG a little bit too, which I guess was a little bit before Canvas.
Yeah, I think it was 2015.
But similar outcomes, not exactly the same if we want, but we're not going to get into all of that today, but similar outcomes as far as improved cardiovascular mortality, non-fatal MI, non-fatal stroke. The composite was a number needed to treat of 62. A reduction in all-cause mortality, number needed to treat of 38, and cardiovascular mortality, number needed to treat of 45. So really good outcomes in the EMPA-REG study. And they also had secondary outcomes looking at heart failure hospitalization, or cardiovascular mortality with pretty reasonable numbers needed to treat. And so that's what prompted them to go on and, one, go on and look at renal outcomes, and then two, after that, I believe, go on and look at the association with heart failure.
Yeah, and do you remember, kind of jumping back, I know kind of jumping around a little bit, but jumping back to canagliflozin, do you remember the adverse effect that everybody was talking about with amputations? Right? Yeah. So I remember I was sitting in a drug rep dinner, and, to the guy's credit, he was trying to, to explain the positive aspects when you hear that there's an amputation risk, that people all of a sudden start tuning out the whole heart failure benefits and things. So to his credit, the physician that was talking, I think was trying to that is something we're looking into, but look, heart failure benefit. Right. And I remember him saying if you really look at the data, it's mostly just toes that are being
it's just the small piece, right? The small things. It's not like their whole leg or something.
Come on, it's not their whole leg, just a couple toes.
It's who cares about a couple of toes?
Just being that's a hard sell, man. I know. But they really were thinking that was going to be ultimately a class effect.
Right. But especially on the heels of Empareg, which was first and didn't have that adverse effect. So there's obviously the adverse effects that we know about, genitourinary infections, hyperkalemia, right?
Yeah, it's going to raise potassium.
Yeah, volume depletion, that sort of thing, possible kidney injury in the short term. So there's those sorts of things that was associated with Invokana as well. But then it got that. What was the exact terminology they used? Small digit.
I think it was risk of amputation of small
something.
Anyways,
they did specify that it was just the toes. So yeah, that was a little bit concerning. And at the time, that smacked into my mic.
The microphone.
200 episodes. And it's the first time I've smacked my mic with my hand
spontaneously.
Just talking with my hands today. But at the time, Invokana was the top seller, right, of the three. And then I remember being at a drug lunch, wasn't a dinner, at a doctor's office where it wasn't a Farxiga rep, it was actually a physician coming to speak on behalf of Farxiga and everything, and really trying to sell the class effect thing. Like you mentioned, like I was referencing earlier, this is what I was thinking about. But at the time, they were working on the declared TIMI or whatever.
Yeah, declared TIMI.
There's only Canvas and Empareg out, and so we didn't really, and there were differences between the benefit you saw with the two, and they're not apples to apples type of trials either, as far as the inclusion criteria and whatnot.
Yeah.
But still, it was hard. It was still hard to say, why would I do Farxiga when I know that Jardiance works?
Yeah, no, for sure. I mean, I remember even with my PA students, kind of saying Farxiga, garbage.
Right.
Jardiance.
It's just because we didn't have the info.
Right, and I remember that as well. The dapagliflozin reps coming around talking about it's a class effect, so we're going to see the benefit regardless. Well, you look at the Declare TIMI 58 study that came out in 2019. Now, granted, when you compare this to the Empareg outcomes and the Canvas, the patients that were included tended to be a little bit more. A little bit higher cardiovascular risk, but the primary composite, as far as the mortality, non-fatal MI, non-fatal stroke, that actually wasn't significant. Now, when we look at cardiovascular death or hospitalizations due to heart failure, that composite that was statistically significant. Same with the renal composites, and so the dapagliflozin kind of realized that they didn't have the same primary outcome results that their competitors did. So they went hard on the heart failure sort of benefits there. So they immediately kind of started pushing towards how can we utilize these in heart failure patients, in renal patients. And, they started working on their DAPA-HF trials, which came out not too much longer after. It was the same year, 2019. So, they were already obviously working on that, but I'm sure preliminary data kind of pushed them then into that
I wonder if the data from, I suppose it probably did, Empareg and Canvas prompted them to do the DAPA-HF trials ahead of time.
Probably. Yeah. I'd have to go back and look and see exactly how long or when those studies were started. But, I think that, when it comes to patients who, were included in those studies, we think of these being like diabetes medications, but the way that they're working is they're blocking some of that reabsorption, basically lowering the threshold for reabsorption of glucose from in the proximal convoluted tubule, so you're excreting more glucose in the urine, but you're still absorbing enough glucose to keep you technically from going hypoglycemic. And so when you give these to a patient who does not have diabetes, they should still be able to maintain their euglycemia. Now, same kind of concept, different mechanism obviously, but same concept with a GLP-1, since these aren't prone to causing, at least as monotherapy, aren't prone to causing hypoglycemia, they can be safely used in patients that do not have diabetes. But I feel like that's something that gets kind of overlooked. We almost just assume it has to be diabetes plus heart failure in order to use these. But no, I would keep in mind these are first line, especially in HFrEF. These are should be first line therapy along with beta blockers and ARNI and
Right.
the standard of care.
Yeah, if you talk to the up-to-date authors, for instance, they kind of
talk to them all the time.
I know we're
buds.
We're buds. They would say do the evidence-based medicines first, the 3 that are evidence-based plus the loop, and then they say consider spironolactone next, and then SGLT-2. But it really depends. It depends on the patient, I guess. But these would be a very reasonable option to do.
I wonder when they published that. Do you remember offhand when they actually made those recommendations for heart failure? Because the April 2022 was the new heart failure guidelines that said basically all 5 medications, including SGLT2 inhibitors and aldosterone antagonists, should kind of be utilized.
Last updated September 1st
of this year.
Yeah.
Up to date. You need to be a little bit more up to date.
They're just opinions.
Well,
you can fight with them.
It doesn't affect my. It doesn't match my opinion, so I don't like it.
Right. So yeah,
we're very opinionated here at Core Consult.
But for a while, we've been kind of saying that, and it's not like they say don't use it, but they kind of say, even with the aldosterone antagonist, they kind of say they still need to be symptomatic. Like if they're not symptomatic, then you don't have to add that on necessarily. So they kind of say the same thing about the SGLT2. So. Anyways, there's definitely data to support using them. But you mentioned the mechanism of diabetes. I did want to mention that in heart failure, they're not entirely sure what exactly is the mechanism that benefits patients, and there's multiple things that it could be. So or maybe all of them together. So I just want to go over a couple of them. So for one, they promote osmotic diuresis and natriuresis, getting rid of sodium, in patients with or without diabetes. So that reduces preload, which is positive. They may also have vascular effects, like improving endothelial function that promote vasodilation, and that reduces afterload. It's also been suggested that they may improve myocardial metabolism, which improves cardiac efficiency. They may inhibit sodium-hydrogen exchanger 1 isoform in the myocardium. It's a long one. And they may reduce cytoplasmic sodium and calcium levels while increasing mitochondrial calcium levels. They may also contribute to, let me see. Of course, they have beneficial effects on renal function, which can improve outcomes in a heart failure. And they have also been shown to reduce the risk of atrial arrhythmias by kind of an unknown mechanism, but it might include reductions in atrial dilation, inflammation, oxidative stress, things like that. So there's a lot going on but they don't think it's related to their glucose lowering effects, which is why we see the benefit with or without diabetes.
Yeah, and I pulled this up on the screen. So for those of you who are watching the video version, this is a really cool diagram that kind of shows their effects for potentially increasing hematocrit. Weight loss obviously can play a role, but then also like Cole was talking about the increased urinary sodium and glucose excretion, leading to that diuresis, reduction in ventricular preload, as well as afterload, and overall that improved ventricular loading conditions. Kind of just from for those of you who like pictures, I'm a big picture guy, so figured
I know. I read my son books now, and they're all picture books.
Nice.
And I'm like, this is great. People ask, what was the last book you read? I'm like, Little Blue Truck.
Little Blue Truck, it's great.
Little Blue Truck, Springtime.
Little Blue Truck that he could. Is that Thomas the Chain? That was a different guy.
This is different. This is more of a nice truck that helps another truck to get stuck in the mud.
Oh, it's nice of him.
It's endearing.
It is. It's nice. I've been reading my son's Star Wars comics. I don't think he understands them yet, but I'm enjoying them.
They're like,
he just stares at me like, "What are you doing, dude?"
They're like, "How many books have you read? Since summer of 2020?" Like 50.
Yeah, really quick ones.
Well, it doesn't matter. I've still read them.
You're talking about people who are like, have you read the 100 most influential?
Yeah, people who are all about like, the last book I read was such and such. What are you reading right now? Oh, I've read a whole bunch of stuff.
Pharmacotherapy, what are you doing? You're reading stuff that doesn't exist. That's what I do. I immediately get aggressive about it.
Actually, I do
that
like
just
to read.
smooths things right over.
That's how Mike makes friends.
Yeah. That's what are you reading? That's a dumb book. Could you imagine? All right, so I guess do you want to start with dapagliflozin for heart failure, the DAPA-HF?
Sure. So like Mike said, DAPA-HF was released in New England Journal of Medicine in 2019. So this, ultimately, what it found was these are HFrEF patients, ejection fraction less than 40, with or without diabetes. Adding on dapagliflozin decreased cardiovascular death or worsening heart failure, as well as all-cause mortality. just to get into some of the specifics. So with the primary outcome, which was worsening heart failure, which they considered hospitalization or urgent visit resulting in IV therapy for heart failure, or cardiovascular mortality, it was 16% versus 21% in the placebo group. And this is, of course, added on to like evidence-based therapy as well. Secondary outcomes were cardiovascular death or heart failure hospitalization. That was significant. And then they, in a lot of these studies, they look at the Kansas City Cardiomyopathy Questionnaire, which is like a symptom score, and they call that the KCCQ, to see if that's improved. That was also improved. And they also looked at worsening renal function and all-cause mortality by itself, but they didn't give a p-value for that. It seems to be significant based on the confidence interval, but they didn't actually give
it's kind of weird.
I don't really understand that.
Like, no, we're not giving you that.
I know. Yeah.
Like, that seems sketchy.
You can guess. But like Mike said, this is the first one that we had with heart failure. So that was like big news 2-3 years ago. Hot off the presses was, we've got SGLT-2s, DAPA-HF. This is the new thing with heart failure.
And one thing I do want to point out too, like for those of you who have the video version, if you look at the baseline characteristics, for those of you who are wondering, this website that I'm using is Wiki Journal Club. If you haven't checked that out, it's a really good list of summaries of landmark trials. They go through like 4 levels of editorial review and to make sure that they're actually accurate. So it's just don't let the word wiki fool you. It's that they are definitely reviewed and signed off by.
Are they associated with Wikipedia?
I don't think so, but I haven't done. I'm not sure. I don't think so though. But I do know that eventually, like the 4th line of like kind of editing is done by the chief medical officer or chief medical editor that basically signs off on it, and he's a specialist in that space. So just kind of looking at the baseline characteristics, if you look at the heart failure medications, 93% of patients were on RAS suppression, 96% were on beta blockers, 71% were on aldosterone antagonist, 93% were on diuretics. So it actually fits exactly with the way the new guidelines from 2022 kind of add the SGLT-2 inhibitor in with those, as part of those 5, primary medications that we're using. It fits in there nicely. And only 42% of patients in the study actually had diabetes.
Right.
So less than half actually had diabetes. That's an important thing too, I think.
Yes. But both groups, with or without, saw benefit, which is important. Though it's important to note as well that it's type 2 diabetes, type 1 diabetes is
excluded.
Excluded. Or anyone, even I guess if they have type 2, but they're prone to ketoacidosis, I saw. It's
like euglycemic ketoacidosis.
Yeah.
It's kind of a weird situation.
It is strange. So that would be a contraindication. Also, so in DAPA-HF, for instance, they excluded patients who had current decompensated heart failure or heart failure hospitalization in the previous 4 weeks. I guess we can save it at the end. I don't have too much to say about it, but there was a trial called the Impulse trial looking at empagliflozin in acute heart failure, and it was good data as well. So we do have some data now in acute heart failure, but in these, it is chronic heart failure that is not decompensated.
All right. So I guess before we jump any further with the heart failure studies, we do need to mention the 4th kid to the party, so to speak, just because that came around, and got approved around the same time. The ortogliflozin, or Steglatro, was the 4th member in this class, at least in the U.S. Their cardiovascular data came out in November of 2020. So again, a little bit late to the party. Their big claim to fame from an overall just use in patients with diabetes was their cost. And so they were about a little more than half the price of the other SGLT2 inhibitors, at least at the time. And so some of the Medicaid plans and stuff, I remember, I don't know if this is still the case. I haven't run into this problem too much, but I know in South Carolina anyways, some of the Medicaid plans preferred that one and would not let you use Jardiance or dapagliflozin. They would only let you use Steglatro, which seems a little bit sketchy. But the A1C, you still get some, the lowering of, from the diabetes standpoint, but the cardiovascular data that came out was a little bit less impressive compared to its competitors. So it was one of those things that, we didn't really see the change in really any of the major cardiovascular outcomes that they were looking for. Heart failure hospitalizations did seem to be some benefit there. and maybe from a renal was like trending towards being a little bit beneficial, but there was not the cardiovascular mortality, MI, stroke, or any of that benefit that we saw like with the other ones. And amputation was the p-value was greater than, they just put greater than 0.05. So it's like, how close were you there, amputation risk? I think the thought process with that and what they were worried about, like, is because of the diuretic effect, you might get some hypoperfusion distally, and that can lead to increased risk of depriving those digits of oxygen, and can lead to increased vascular problems and amputation.
Right.
But so that study was kind of a little bit of a letdown, I guess, as far as like the whole class effect thing. So they're definitely not created equal.
They've been preaching that. They've been screaming about it for a long time, but there's too much justification to say that there is not necessarily a class effect for these. There are preferred ones. Yeah,
and I've told my story about the one rep for this program saying for this drug, saying that I don't know why we get so caught up on it, because I asked him about why should I use this one, but based on the outcome stuff, and he's like, I don't know why we get so caught up on outcomes. And I looked at one of my PA buddies, that's Alex, that's been on the podcast. We just kind of looked at each other and we looked back and we're like, we kind of want our patients to live. So I think,
what else is there to get caught up on?
What else are we going to get caught up on? The fact that you're not making enough sales?
The money?
I don't know. I appreciate the sandwich from Chick-fil-A or whatever they have, but that's a weird thing to say and he was a pharmacist too. I was like, dude, you're making us look bad. You're supposed to be on my team.
I mean, I feel for the people who work with those drugs that have better drugs, but then have to try to convince you to prescribe these.
That's got to be tough.
Yeah.
I would be the worst at that.
Is there any reason? There's no reason to prescribe his medicine.
You'd have to just go off of like which ones are getting. I think their big thing was like, hey, if it's a Medicaid, they'll only pay for this one, so you have to use
it's all based on
crappier drug.
Some nonsense contract that's been established.
But yeah, I would be the worst salesman for that. Could you imagine? Like if it was like Trulicity or Mounjaro or something I really believe in, I think I'd be a good salesman. If I had to go in there and sell Januvia, like, hey, this is never mind, this drug sucks. Yeah, I gotta be honest with you guys.
See, I would be a terrible salesman regardless. Mm-hmm. But that would be so much worse. And what would stink is maybe you get hired on and you're doing this great drug that's like number one and all that stuff.
We're going to transfer you
right, over and then you get moved and it's like, I can either quit my job or I can try to sell this thing.
That's tough.
Might be quitting your job.
Yeah.
I don't know, but it's not like you can just,
it's tough.
That's why that's not my space.
Yeah, and I try to be nice to them when I talk to them, but I do have, sometimes it's like they're just going on and on about how great the drug is. And I'm like, yeah, but why is it great?
I know.
Can you just give me I need a reason.
I know.
And sometimes it's one of those things.
Yeah.
Anyways, all right. So, Sotagliflozin, probably the least on my list of SGLT2s. That's the one I kind of save for if I have no other choice. Yeah. Medicaid's making me. But we definitely have more data in the heart failure space, which has gotten a lot of people excited. So with empagliflozin, we had both the Emperor reduced and the Emperor preserved studies that came out. And when the Emperor Preserved study first got kind of released, the primary composite was cardiovascular death and heart failure hospitalizations. And they said it was like, they met primary, outcome. I was so excited because we haven't had a medication in preserved ejection fraction that actually prolongs life in ever. Spironolactone's the closest we got, and that's kind of murky with the Top Cat trial.
Right.
But I was like, oh, heck yeah, finally. And they were like, driven by hospitalizations.
Yeah.
No.
Yeah.
Preserved ejection fraction, you've done it again.
That being said, it's not bad.
No,
it's still good. It's just not what we have in HFrEF.
Yeah, it's very interesting, isn't it?
It is.
That, no matter, we've tried all these different classes, and one of those things we just don't really see.
It feels like it's going to have to be something novel.
Yeah,
I don't know enough about it. I feel like we probably heard some pretty good ideas from that guest we had on when we talked about it.
Mm-hmm. The cardiologist.
Yeah, but I've already forgotten everything that was said on that podcast.
You should go back and listen to it.
I should.
It's on Spotify.
I should have.
You can listen to it anytime you want.
Sure can. Yeah, but at least we have something. So I was chatting with the authors of the up-to-date article the other day on heart failure with preserved ejection fraction, and they suggest any patient be on with HFpEF, be on an SGLT-2 and a mineral spironolactone, essentially. they suggest both over one or the other, even though there's not really, we don't have data of them being used together in this instance. They still suggest both. I
think the guidelines themselves actually rate the evidence for SGLT2 inhibitors a little bit better, I believe. But I know anecdotally, I can say for sure that I was working with a patient who was seeing me for hypertension and had to have a history of HFpEF, hadn't been to the cardiologist in quite some time, was having really bad dyspnea and was just really symptomatic, fluid overload. Kind of got meds started back, but I had mentioned using Jardiance, and we have Jardiance really cheap at our pharmacy, and so she being uninsured, she hadn't even thought about that before. Kind of explained it, how it works and all that. Started just Jardiance 10 milligrams, which is actually what they used in the Emperor Preserve study, and within probably, I think she came back about 3 weeks. She's like, I have never felt better. She's like, I'm like walking like down the street and back now and getting some exercise. She's like, it was ecstatic about it. And I was like, look at that. Guidelines work.
That's great. So what were people doing before this? I feel like whenever I would hear HFpEF, I'd be like, we don't have anything to treat it with. They were treating underlying conditions. I know that. But were they not using spironolactone? So I know there was.
I think they were, and
that
whole controversial with the levels not being found in patients that were involved in the in Russia and overseas, Georgia and stuff. Yeah. So, all that aside, like I think that's the closest we had. It had gotten to any kind of like benefit from more so than just a hospitalization standpoint. But yeah, I think it's just one of those things they were just kind of trying their best.
And these patients, you are going to kind of do it regardless, but it is suggested to get a BNP or a in-terminal pro-BNP, and you can monitor that. They say if you start them on SGLT2, which they suggest starting first, these are up-to-date articles, suggest starting first, and then adding the spironolactone on a couple weeks later. If you see the BNP go down or normalize, you still should add on the spironolactone regardless and titrate to tolerability.
Yeah. And I'm going to change it back over to the computer screen here. Just I don't know if you guys have ever seen these infographics that cardio nerds do, but they're really cool. They do a lot of the new cardiology studies that come out. They'll do like these very nice infographics. This is the episode of shout outs for our colleagues.
I know.
So I like these guys a lot. I kind of stumbled across these one day. They have a podcast and stuff as well. But their infographics, I really like. Like I said earlier, I'm a big picture guy, so I like stuff like this. Very easy. But yeah, I saved a lot of these, and they're free. You can like see on their website here. You can get on all these.
You're the big picture guy, and I'm the details guy.
Yeah, there you go.
It's a joke. Well, not a joke, but a play on the big picture.
All right. Do you have anything on Emperor Reduced?
Yeah. So going back to HFrEF, so we talked about the DAPA-HF. And then after that, this was 2020, I guess about a year later, from DAPA-HF, the Emperor Reduced was released, and this was empagliflozin's heart failure study. Bottom line, with or without type 2 diabetes, there was a reduction in cardiovascular mortality and hospitalization for the progression of heart failure. Breaking it down a little bit, that was a composite with the hospitalizations for heart failure specifically. It was, of course, significant. And I didn't see anything about separating out mortality by itself.
I don't think mortality was actually statistically different, right?
Right. So, well, I didn't even see where they separated. So I guess I would presume that it wasn't.
Because what's really weird about that is if you think, and I guess it goes back to like the inclusion criteria and all that, but if you look at EMPA-REG outcomes, granted they use the 20 and 25 milligram doses, but you had the cardiovascular mortality on top of the hospitalization due to heart failure risk reduction. But then when you look at dapagliflozin in that DECLARE TIMI, the initial study, they had the hospitalization due to heart failure risk reduction, but they didn't have the mortality. And then all of a sudden it's like flip-flopped
in heart failure.
In heart failure, the actual heart failure study.
I know.
Very strange.
So it's interesting. So if you have a patient with diabetes and heart failure, which one do you go with?
I personally go with Jardiance.
That's what I would do too.
And then if it's just heart failure, then the other thing is, the patients in EMPA-REG were not as cardiovascularly, didn't have as high of a cardiovascular risk as the DECLARE patients did. So that could throw it off.
Does it matter like their control of diabetes versus control of heart failure. Like if it's really severe heart failure, a lot of exacerbations, but they've got diabetes, but they're just like hanging around, 7, just everything's good versus
You mean it's how I pick between the two?
I'm just wondering if that would sway you or you'd still go with Jardiance.
Yeah, I mean, I think at that point I would be a little bit more...
I think the data is more compelling with the cardiovascular protection and diabetes.
Yeah, for empagliflozin.
But
without diabetes, then dapagliflozin possibly. Even though but you can't really compare them like that, so that's where it gets hard.
Right.
We're just basically having our own conversation now. You guys are just
I'm just thinking about what I would do.
We're just pontificating.
I don't think there's a wrong answer.
Yeah, no, I don't think so either. And I see both of them being utilized by cardiologists locally. Yeah. And like I said, I've used myself more Jardiance because it is cheaper for us. And the other thing is, did you happen to see anything of why they use 10 milligrams and not 25?
Did not.
I'm wondering if it was the potassium risk since they're already on aldosterone antagonist and all that. But I mean,
because in the EMPA-REG, I bet they weren't on as many potassium increasing medications.
Yeah, I wouldn't think.
So that's interesting.
But yeah, it's just like, I don't know why they did 10 and 25 in the EMPA-REG, but then they jumped to just the 10 when it came to the Emperor studies. So it's kind of weird. I'm sure there's a reason for that we probably could have found, but
they did mention
too late.
Volume depletion was greater than placebo in Emperor reduced, and I'm sure that it would have been more significant with higher doses as well. Yeah. Because these patients are also going to be on loop diuretics for the most part. But I guess DAPA-HF they would have been as well. And
the renal dose limits or renal dose cutoffs, like a threshold, I guess, was a lot lower in this study. It wasn't, I think Emperor Preserved was like down to 20, if I remember correctly. I'm pulling it up. But let's see. I hope I'm right about that, as I just blurted it out. Sometimes I should check. I thought I had it right in front of me. Do you see it anywhere?
I don't see a floor. I see that over 50% had an eGFR less than 60, but I don't see what they excluded.
That's weird. I could have sworn. Maybe I'm thinking of the renal study or something. I don't know. I believe it was lower. And basically the thought process with, just to kind of throw this out there, it's a little off topic, but and we saw this with that study that Cole mentioned earlier, the Credence trial with canagliflozin. When you add canagliflozin into a RAS inhibition therapy, you're basically, the renal protection that you get will maintain over the course of a patient's renal function declining. However, the A1C lowering ability starts to decline. So like the A1C lowering from like baseline to, as the renal function declines, sort of like eventually meets placebo, but the renal benefits are still there. They remain behind. So it's one of those things that, just because they have the renal dose limits doesn't mean that it's going to necessarily, we still have our cutoffs, but it doesn't mean that we're going to cause harm necessarily, like when we get down to like 30 and whatnot, but we can't expect to have that A1C lowering to be to the same extent.
Right.
But the medications can still be beneficial from both kidney and heart failure standpoints.
And that makes sense from their mechanism of action standpoint.
But I think that's an important thing that I feel like gets overlooked a lot too.
So that's empagliflozin and Farxiga, dapagliflozin. But I'm just going to start using the brand names. Invokana.
We're done. We try our best.
I've said it for a while, and I'm going with brand names. Invokana does not have a strong heart failure study like this. If one's ongoing or if they're not.
I have to look. I'm not familiar.
They have the data. I guess it's mainly taking it from Canvas, I presume. But patients with diabetes, you have a heart failure hospitalization benefit, but you don't have any information in patients without diabetes.
Yeah. Plus, they report, instead of number needed to treat, that's what I like. I like number needed to treat, very simple for my tiny brain to understand.
They do the 1,000 patient years.
They do the 1,000 patient years. I'm like, don't you dare put that. I instantly hate your study if you put that.
Now I have to go in, convert 1,000 patient years to number needed to treat.
And if you think I'm going to do the math, you're crazy. I'm going to immediately Google the calculator and convert it. But it's a much higher number needed to treat than the...
I don't understand. The only thing I can... It makes me wonder when we say these things if there's something statistically going on behind the scenes that we just don't understand in any way, shape, or form?
I would guarantee that's the case. There's somebody who's really good at stats that's going, these two people are the dumbest guys ever.
You know how you have to put patient information on like a, what is it, an 8th grade reading level or something like that? You need to keep these studies to a Mike and Cole reading level.
Right, which is definitely
number needed
middle
to treat,
school at the best.
P-values, confidence intervals. That's
don't even put confidence intervals. I need a P-value that I can understand.
Less than 1, greater than 1. I got that.
Maybe.
But, the statistical tests that don't show a p-value, they show some other nonsense. Don't do that.
Don't do that. Us. That's rude.
Don't do that to us.
Yeah, it's embarrassing. It makes me feel dumb. So what about that SGLT-1 and 2 inhibitor?
I know. It kind of reminds me of
Sotagliflozin.
Kind of reminds me of the it's escaping me now, but the GLP-1 and
GLP-1.
GLP-1. Yeah, it's like hitting two different things.
It's very much like that, except it doesn't work
as well. Yeah.
No, for those of you who are not familiar with that, the study was called Soloist WHF trial, and that one came out, I believe, in 2021, early 2021. And they were kind of following the same, trends of trying to show that when the primary composite of heart failure hospitalizations, urgent care visits, and cardiovascular death would be reduced, which that composite was, but unfortunately it was again being driven by hospitalizations, urgent care visits, not cardiovascular death. When you separate them out, secondary outcomes, cardiovascular death was not significantly different from placebo. But this is a SGLT2, SGLT1 dual inhibitor. So on the SGLT2 side, you're getting the increased urinary glucose excretion and diuresis and all that. And then the SGLT1 inhibition side, you're getting the delayed intestinal glucose absorption. And, the thought process would you get that synergistic activity of both of those transporters that you would get better results. But we're not really. I don't even know if this drug it hasn't been approved in this country, I don't believe.
Well, I was seeing that it was investigational, so I was trying, but I saw that, but then I also saw it has a brand name of Zynquista. Maybe that's in a different country.
Overseas, yeah. If only there was a website called Lexicomp or Pearls or anything like that would have it on there. I will say Lexicomp probably will have this one if it's located in another.
As far as I can tell, I really can't. I don't know. I'm going to say no.
I'm almost positive it's not approved.
I'm going to say no, not approved.
We're really, kind of
the new drug application was accepted in July.
Okay, but not actually
not approved
yet. Okay, good job. Okay. Thanks, Google.
Yeah.
And they have a nice breakdown of this one. I'll show you on my screen real quick. For those, again, pulling up, shout out to Cardio Nerds, but they have put in another really good infographic kind of showing this one. But yeah, so it's out there. Again, cardiovascular mortality was not affected. So we're still falling just slightly short of that goalpost.
It had some interesting side effects too. In that trial, diarrhea was about twice the placebo was, which I don't usually associate with
the SGLT1 component.
SGLT1. And then severe hypoglycemia was, of course, significantly higher.
Yeah, because you're delaying that intestinal glucose absorption, so it's basically like affecting the GI tract, almost like a metformin, I would think.
Yeah.
So,
is there any other drug like that?
I think there's an SGLT1 inhibitor that's like for something completely different. I can't remember what it's used for, but there is something that's approved. But it's something that we never deal with.
Interesting.
Let's see. I'm Googling stuff. This is the episode of just Googling. We're learning right along with you guys.
It's the best way to fact check us.
Yeah, AJ's studying tonight, so he's not here to fact check us since he got on me so quick last time. Accused me of making up my own questions. So disrespectful. We miss you, AJ. But yeah, this is the SGLT1 inhibitor is talked about as the main one that keeps coming up is that Sotagliflozin.
Yeah.
But
primarily this one.
Yeah. I could have sworn there was another drug that was just that, but I don't know. Whatever. Maybe you know what I'm thinking of? I'm thinking of GLP-2 instead of GLP-1. There's a GLP-2 that I was like, what is that? That doesn't exist. I looked it up. I was like, crap, that exists.
It's a thing.
Yeah, that's what it is.
I'm also seeing that they're trying to get this Sotagliflozin approved for type 1 diabetes.
Which I don't really understand how that would be more beneficial.
I don't really understand.
Just from the GI effects.
It's old press release, but maybe that might end up happening.
Super old, like 2021.
No, it's older than that.
Oh, okay. So, I think ultimately these meds are going to be very widely utilized. The more the data comes out. Cole, you mentioned the acute, it was decompensated heart failure, right? With the empagliflozin, the Impulse study.
Yes, it was acute. They called it acute heart failure, but yeah, because that was kind of the big piece of the puzzle that we didn't have. We have a lot of data now in chronic heart failure, but we didn't really have anything in acute heart failure, but it did show promise. I can't remember. I'm not looking at the exact outcomes, but I believe it was reduced hospitalization or reduced time to hospitalization, and along with some other things like the Kansas quality symptom score was improved and that sort of thing. And I believe they got it started. They got it started in the hospital, I think 24 hours after admission, up to 5 days. And it could have been what they called a de novo acute heart failure, like a new onset acute heart failure, or a decompensation, and they saw similar outcomes.
I like how you said you don't remember anything about it, and you just went on. And
I had to see it in my brain as I was talking.
Cole has a photographic memory, everyone. You heard it here first.
I wish.
He's just staring off into space and just quoting the study.
Well, I also see, going back to Sotagliflozin, that since that old article happened, the approval for type 1 diabetes was denied. So, yeah.
Turns out it doesn't work.
We got hope, and then it was dashed.
Yeah, in the same episode. Yeah. How the tables have turned. Do we have anything else we want to go over with SGLT-2s? I know it's kind of like a very broad overview, but
it was broad. But I mean, we went into more detail on some of the studies than we have in the past. But no, we threw a lot of names at you, so try to internalize a few and flip them on your colleagues and say, "Hey, have you heard of Impulse?
Yeah,
have you heard of this one?"
Also, if you guys haven't noticed, anytime I bring up something that could be kind of taken as a negative about the episode, Cole, during the episode, will point out that we did a great job. He's very positive.
Just totally flip it on his head.
Yeah, and he was like, no, I think we did great.
Completely disagree.
No, it's good. It's good. We need his positivity around here. I also want to make sure that we mention our podcast sponsor, Pearls, Pyrls, is a fantastic drug info app that is getting bigger and bigger each month. I'm going to switch over to my computer screen again because they got brand new CDC pneumonia vaccine recommendations updated for 2022 with our PCV 20 and 15 recommendations on there now, as well as the influenza vaccines that are updated for 2022, 2023 flu seasons, which is upon us basically. And they kind of breaks down all the age recommendations and the available products, but those are all available. So if you are not a Pearls subscriber, go to your computer or your phone, pull up Google Chrome or whatever you use, put in pearls.com/CoreConsultRx. You'll get a welcome Friends of Core Consult RX, because that's you guys. And you can get a free account with some free PDF downloads, some really nice charts. And if you do like it, definitely encourage you to check out the paid version. There's so many good things on here. And it grows. Every time I pull the website up, there's more and more stuff added. So Derek's doing a great job, and we really appreciate his support of our podcast and Core Consult in general. So, I just, appreciate his help, and make sure you guys give him a look, check it out, and sign up for at least a free account. See what you think.
For sure.
Also, again, if you haven't checked out Free CE's websites, again, from the video version, I'm just kind of giving you a few examples. You can go up here to learn, click on podcasts, and you will see a whole list of podcasts that are now accredited based on various topics. And, we really appreciate PharmCom, Free CE continuing to work with us. And I was looking back actually randomly through some emails, and it's been over a year that we've been working with them now.
Yeah.
So yeah, we have quite a few episodes banked. So you can notice even on some of mine, this is my wife's account actually, so you can see she's doing she's getting her CE from my podcast. She's like, "Can I have the answers?" I said, "No. I need to see you learning and passing those tests."
Been here long enough that some of them are going to start expiring. I think they stay up for like 2 years or something like that.
Yeah. 2023 I think is the earliest one on here. Okay. So we're good. You guys got plenty of time. Check out that unlimited membership. You can't go wrong. There's so much good stuff on there. Cole and I both use it even well before we were working with them. But big thanks to freece.com. Check them out. If you have any questions for Cole or myself, you can reach us via email. That'll be in the show notes. We have the social media platforms available. If you want to send us a DM, if you want to be a little bit cooler than email, you can reach us via text. That'll be in the show notes as well. You can also click the text button on Instagram, and it'll take you right to the phone number.
Do you want to tell them what to expect in episode 200 or still keep it a secret?
We can tell them. So I talked to our good friend and mentor, Dr. Wayne Wirt, and so he has agreed to come back on. He was the probably the Jedi Knight of to use a Star Wars reference.
The best way to say it.
The Jedi Knight of
master.
pharmacotherapy. Every time I start to feel like I'm getting a handle on pharmacotherapy, I'm feeling pretty good about myself, I just go hang out with him for 10 minutes and I get humbled very quickly. So he's done more in his career than I think I could ever even dream of doing, and he's still rocking and rolling in his 70s. And so he has been gracious enough to come back. He was there for us on episode 100. He's come back for episode 200, and we're very thankful to have him back and taking his time. It's pretty crazy that someone like that, who people pay all over the country here, speak, and he's just going to come hang out with us, and he's coming in studio too.
Oh, nice.
Yes. So, very excited about that.
Was it COVID days?
Yeah.
Oh, yeah. That's why he was virtual last time.
So he said, I asked him if he, I'd give him the, he said, yeah, I'll come, give me the address.
Nice.
So he's coming from hot dog ministry.
Oh,
he goes
very
and
nice.
he's in his 70s and he's still cooking hot dogs and handing them out to the homeless downtown Charleston. Probably one of the nicest guys you'll ever meet.
Yeah.
So big, I owe him a lot of thanks in my career from his mentorship. But we'll hang out with him, hear about what's going on. I told him maybe we can even get his thoughts on what got him excited as far as new drugs and all that fun stuff. So make sure you check that out. If you have any questions for him or anything like that, shoot us an email. We'll make sure that we ask him. And other than that, anything else, Cole?
That's all I got.
AJ, who's not here, we'll just pretend he is. he's got nothing else either. Good luck to him in his test. And we'll see you guys on the next episode. Next time coming up, episode 200. See you then. Have a good night. Bye.